So hello again, we're about to get started. As I said, my name is Dr. Naina Harawa. I'm the co-director for the National Coordinating Center for the Resource Centers for Minority Aging Research. We are based at UCLA, and today is the first of a webinar series that we're starting, which focuses on approaches to health research on minority elders. We don't yet have a follow-up date, but our goal is to be doing quarterly webinars with different topics, specific area. And so look to your future emails for the dates that are coming up. We're really excited to have you joining us today and to be presenting this specific webinar by Bryan Tysinger of the University of Southern California. They run a RICMAR program that's focused on economics and finance issues among minority elders. Bryan Tysinger is the Director of Simulation and Data for the Roybal Center for Health Policy Simulation. He holds master's degrees in both policy analysis from the Pardee-Rand Graduate School and a bachelor's degree in applied mathematics. He has done quite a bit of trainings on this specific resource around microsimulation as well as this method, including supporting several RICMAR scholars in their work. We'll be turning the program over to him shortly, but we wanted to just tell you a little bit more about the RICMAR more generally. The RICMAR program is a national program that's funded by the National Institute on Aging. There are 7 centers across the U.S. The specific program was initiated in 1997 with a mission to build infrastructure to improve the health and well-being of older diverse populations and by reducing health disparities in the U.S. And it's designed to achieve this mission through creating research infrastructure, and that infrastructure is designed both to mentor and sustain research careers of people who are focusing on the health of minority elders, as well as to enhance the diversity of the professional workforce of people who are doing this type of work. If you're interested in more information about the RICMAR program, you're welcome to email us. You also can put questions in the chat. We'll try to respond to those as well. A few quick housekeeping things before we get started. We just ask that individuals mute their phones, including if they go on hold during the session. And I've put up here both the contact information or some more information about Mr. Bryan Tysinger's background, as well as the grant information for the RICMAR program itself for both the Coordinating Center and the USC Center. So with that, I'm going to turn it over to Bryan. If you have questions during the program, please put them in the chat, and we will summarize them at the end, or there will also be time for people to ask them verbally at the end via phone or computers. Thank you.
Okay, so it says I'm unmuted, so I assume everyone can hear me now. So my name is Bryan Tysinger. As I said, I work at the University of Southern California. I've been here for about 6 years. I have a background in applied math and public policy, and I spend most of my time working on our microsimulation projects here at Schaefer Center. And so I'll be talking about those projects now. Okay. So I don't think I have to convince this audience that the U.S. is facing important questions regarding the future of health in the U.S. We have issues of health disparities, the future burden of disease, access to care, and healthcare costs. There are lots of policy questions involved with these issues and lots of policy solutions that need to be analyzed. And the big challenges here are there's a lot of complexity with the health processes, there's powerful trends in demography, health behaviors, and then new medical technologies coming online. So here at the Roybal Center for Health Policy Simulation, we host 2 microsimulation models. The older of the 2 is called the Future Elderly model, and it's literally also the older populations that we're simulating. It's based on the Health and Retirement Study, so it's people 51 and older. And then the second model that we have is called the Future Americans model, which is based on the Panel Survey of Income Dynamics, and we focus on people ages 25 and older. The basic way to think about the way these models work is we're trying to forecast what the future of these surveys might look like. So let's say the year is 2020. If they fielded the HRS, what might the responses look like? And we think that the responses might be a little bit different because demographic changes, health risk factors are changing, et cetera. In addition to having these nationally representative versions, the Future Elderly Model and the Future Americans Model, we have versions of both that are at the Los Angeles County level. This was actually one of our earlier RICMAR projects that we worked on, was adapting the Future Elderly Model for LA County, and we've continued that work. The basic idea there is taking the nationally representative surveys, reweighting them to make them look like they represent the County of Los Angeles, and then making sure that we're matching mortality trends and then implementing migration trends that we expect to see at the LA County level. And we can use the model then to answer all sorts of questions at the local level for us. So the center that I work for, it's initially started in the late 90s at RAND. Initially, I think it was funded by a grant from the Social Security Agency, but over time it's been funded mostly by the National Institute on Aging. We're a Roybal Center, and I think we're in our 13th year of funding on that. We've been funded by the MacArthur Foundation, Department of Labor, National Academy of Sciences, CMS, et cetera. It's been a very productive project. I can send a list of publications around if people are interested. But I'll draw your eye to the bottom right part of this because we use these models to analyze a lot of different features or different outcomes. So we've done lots of work on obesity, smoking, cardiovascular risk factors, but then we also do more speculative work on the value of delayed aging. We've done a lot of deep dives into Alzheimer's disease and related dementias. And then we've done a lot on Medicare reform, Social Security policy changes, and then also understanding the new medical technologies that might be coming online, what the value of those might be. So sort of a snapshot of where we are. Who we are, so here at the University of Southern California, there's about 20 people who work with the microsimulation, not full-time certainly, but we have, at last count, 9 faculty members and fellows, a few postdoctoral fellows. Our programming core, there's about 5 of us in the data core who work on these models. I'd say roughly a little over 2 full-time people. And then at any given time, we have a handful of doctoral students that are using the model either for their entire dissertation or for a paper within their dissertation. We do a lot of work internationally, so in addition to the HRS-based model, if a country has a survey similar to the HRS, we can implement the simulation there. So we've done work in Japan, Singapore, Korea, Canada, Mexico, and Europe, and we're always looking for additional collaborators to work there. And I mentioned here also the Los Angeles County Department of Public Health. And then I should say we also have, for particular US-based projects, we collaborate with individuals around the US as well. We have collaborators at University of Chicago, Harvard, Stanford, et cetera. Yeah. Okay, so the current iteration of the Roybal Center is focused on 2 big areas. So the first is policies to mitigate the social consequences of health disparities. So I think that that's probably very fitting for this group. And then these international lessons, which explains why I have all those international collaborations on the previous slide. So now, what I'm going to do is I want to give you a sense of what the model does, what it's capable of, how to think about using it, and then I'll give you a handful of applications that we've done. But I'd encourage you to think about the data sources that you're familiar with, so the surveys that you're used to working with, the kinds of questions that are asked. And the way to think about the model is, like I said, it's like simulating the future of the survey. And so you can imagine that any questions that are asked within the PSID or the HRS or a similar type of survey could be thought of in the same kind of context as what we're doing. So if I don't mention a topic that you're interested in or a particular variable that you're aware of is in the HRS or the PSID, it's fully possible to develop those things and simulate them out. Okay, so the simulations, we focus on the complex interaction between health, mortality, and economic outcomes. So the kind of philosophical perspective that we're going to take is that demographics and risk factors are going to lead to health outcomes. Health outcomes will then lead to outcomes like medical spending and things like that. And then there are also going to be economic outcomes as well. So, for example, a person who develops heart disease at a young age might leave the labor force earlier than they would have otherwise. But the flow is always from health through to economic outcomes. I fully admit that there's an endogeneity problem typically, that we also know that economic factors impact health, but the perspective of the model, because of the way it was developed, really focusing on new medical technologies and interventions on health, we took the perspective of health flows to economic outcomes. Let's see, so I mentioned that it's estimated on these two large nationally representative data sets. And then the kinds of economic outcomes, I'll cover this more on a future slide, but we focus on wealth, earnings, work, federal program participation, such as Social Security, Supplemental Security, federal disability. We predict Medicare enrollment, Medicare costs, and also Medicaid is on here as well. And then the structure of the simulation is that we've estimated all of our model based on real people. We begin our simulation with real people, so these are actually the respondents from the HRS or the PSID. And then ultimately we're going to need synthetic replenishing cohorts, which I'll talk about in a bit, but those are also going to be based on real people that we see in the PSID or the HRS. So I think the real strength of what we're doing is we capture the actual heterogeneity that we're seeing in our panel survey data sets, and we're not resorting to entirely synthetic populations where we're doing our best to match a distribution. We're using real people. Okay, so in terms of the set of things that we're simulating, this isn't the full set, but it'll give you some sense of what's going on. So the structure of the model is going to be a first order Markov process. And so what that means is that what's happening at time t is going to be the of time t plus 1. So within the survey, you can think of this as the responses that we see in the 2014 HRS, we can predict based on in the 2012 HRS, if that makes sense. And so the big health outcomes that we're going to be predicting will be mortality, cancer, diabetes, heart disease, and other chronic diseases. And so those are going to be modeled as incident of disease because based on the wording of the question in the survey, they basically ask, has the doctor ever told you that you have diabetes? And so what that means from our perspective is that if they've been told that, they always will have been told that. And so it's an observing state, and so we're modeling incidents. We do a lot on ADLs and IADLs. So these are the activities of daily living, instrumental activities of daily living. So things like, can you get out of bed? Can you cook a meal? Things like that, very functional status indicators. We model smoking, mental distress, subjective well-being. We model BMI as a continuous variable. And then I mentioned the set of economic outcomes, just reading the risk list quickly. The ones I missed before would be, we model nursing home status. And we also do a lot of the sort of the informal kind of transfers that you see in society. So in the bottom right panel, you see the help hours received and volunteer hours in the community and grandkid care hours. These are things that we developed to really try to understand that dimension of the elderly population. So there's a lot of heterogeneity, a lot of depth, a lot of variety in terms of the things that we're modeling. So just to give you a sense of what a typical transition model would look like. So like I said, for something like diabetes, we'll be modeling the incidence of diabetes. And so for anyone who has not developed diabetes in the previous wave of the survey, we're going to have a transition model that would predict if they would develop diabetes in the current wave of the survey. And so that's going to depend on sex, race, education, and a lot of childhood characteristics. So these are things like child wealth, child health, child self-reported health, other childhood circumstances. And then things that vary over time will enter just by how they were observed in the previous wave of the survey. So, for example, age will enter as the lag of age, smoking status will be the lag of the smoking status, exercise, the lag of exercise, BMI, the lag of the BMI. So anything varying in time will be just the previous observed value from the survey. Okay, so the simulations are very data-driven. This is not us, writing up a model for how we think it works and assigning a parameter value. We're actually going to estimate all of the transition models, all of the cost models that we're using within the simulation. So if you see our code base, there's a lot of code, and it's because we're pulling together a lot of data sources and trying to really be careful with the data and understand what's going on and have models that we think are reasonable. So within the Future Americans model, like I said, the host data source is the panel survey of income dynamics. For the Future Elderly model, it's the health and retirement study. But then we're going to supplement all of those with additional data sources to do deeper drill downs into particular areas. So for example, if we're doing research on Alzheimer's disease or related dementia, we'll focus on the ADAM supplement to the HRS to really understand if we're capturing diagnosed Alzheimer's disease well. For our replenishing cohorts, the synthetic cohorts that are eventually going to come into the simulation, we're going to need trends on health risk factors. And so for those, we're going to look to national representative surveys like the National Health Interview Survey or the NHANES. And for medical costs, we'll look to the MEPS and the MCBS. The MEPS will be for the non-Medicare population. The MCBS will be for the Medicare population. And then for other variables that we're friends, such as education or marital status or number of children at a given age, we'll turn to the American Community Survey or the census, or sometimes we go to the literature and just pull off a parameter. Okay, so I'm going to walk you through the two types of simulations that we do. So the first is the simpler of the two. It's a cohort simulation, and the basic idea here is we're going to take a group of people and we're going to age them through death. There will be no replenishing cohorts, but we'll get to that in just a second. So this is an example of a FAM simulation. So if this were FEM, you would simply replace population age 25 and 26 with population age 51 and 52. So it's a pretty general slide, but you can think of it as applying to both sets. So what we'll do is we'll read in the 25 and 26-year-olds in the given year, and immediately we're going to calculate outcomes for these individuals. So this is where we'll calculate medical expenditures based on their health characteristics. We'll calculate their disability benefits based on their work history. We'll calculate the Social Security benefits if they happen to be able to retire, for example. And then now we're going to age the population by 2 years. So I don't literally just mean add 2 to their age. I mean that we're going to apply these transition models that we've estimated in the data to predict if these people are going to develop a disease, leave the labor force, get married, have a kid, et cetera, et cetera, et cetera. And so you'll see that this happened in a 2-year time step, and that's because we're mimicking the structure of the survey. So you could think of it, if the PSID had existed in 2016, we're now trying to predict what the people in 2018 who had participated would now look like. And so now we'll do the same thing, where we're going to calculate their policy outcomes. So once again, figure out what their medical expenditures are now that they might have developed diabetes, and now that they might have left the labor force, et cetera, et cetera. And now we're just going to turn the crank. So now we'll age the population again by another 2 years, calculate all of those policy outcomes again, age them another 2 years, policy outcomes again, et cetera. And we'll typically do a cohort simulation like this through death, because we'll calculate ultimately life expectancy, in total quality adjusted life years, disability free life years, variables like that. And we can calculate lifetime medical expenses as well. Okay, so now I'll talk about the population simulation, which is similar in structure, but a little bit more complicated. So here, instead of starting with a population 25 and 26, we're going to start with our entire population 25 and older. So if this were a future elderly model, it would be the entire HRS population 51 and older. but here I'm talking about FAM, so just 25 and older. I'll do the same thing where I calculate the policy outcomes. And so what this lets me do now is I could say that in the year 2016, since I have this nationally representative population 25 and older, I can calculate what is the Medicare expenditure for 2016. How much did Medicaid spend in 2016? Of course, for the 25 and older population. So now I'll do the same thing where I'm going to apply these transition models. And so, you know, individuals will now develop diabetes or leave the labor force or not develop diabetes, whatever the case may be. And but I have a problem here because now I've aged everyone 2 years, and so now my youngest person in the simulation is 27 instead of 25. And so this is where these replenishing cohorts are going to come in. And so these replenishing cohorts, these are actually probably the most complicated part of our simulation. But the idea here is that we want to make sure that we have a replenishing cohort coming into the simulation that looks like what we think people might look like in 2018 or 2020 or 2022, as you'll see in just a second. And so first order, we need to make sure we get the demographics right. So, you know, if we have a trend in more Hispanic people in the US, then we need to make sure we have more 25 and 26-year-olds who are Hispanic. If we think that people are smoking less, then we need to make sure that this group is smoking less. If we think that obesity is going to continue to go up, then we do the same here. So there's a lot of assumptions that go into this. It's really driven by trends that we're seeing in the data, as well as the demographics that we get from the census. But the main idea here is that if obesity is increasing, then we think that things that are correlated to obesity will probably also be increasing with these replenishing cohorts. And so like hypertension for these 25 and 26-year-olds will probably also be a little bit higher if we see this increase in obesity. If you have deep questions about this, please don't hesitate to ask me more. It's one of my favorite parts of the simulation, but I think that's enough for now. I think you get the flavor. Okay, so now that we've brought in our replenishing cohort, we have a nationally representative population for 2018 of people 25 and older. And so I'll do the same thing. I'll calculate all of my policy outcomes for that group of people. So that's our medical expenditures, Social Security benefits, et cetera. And now I'm just going to turn the crank. And so now it's 2020. Once again, I have a population 27 and older because I've aged everyone through 2020. And so I'm going to do the same thing where I'm going to need to bring in a replenishing population of 25 and 26-year-olds. And now, once again, I'll calculate my policy outcomes, and I'll turn the crank again. And so if you were to look at what these replenishing cohorts look like, I have a typo on my slide. That top right box should say 2022. You would see that the demographic characteristics are going to match what the census has. Based on the trends that I'm imposing, they'll be a little bit heavier on average. They'll smoke a little bit less on average. They'll be a little bit less likely to be married, have slightly fewer children. But it's all designed to be very flexible so that if people disagree about the assumptions inherent in the way we've implemented this, then we can change them and see what the impact of that might be. Okay, so that's the flavor of a population simulation. So the two big types, cohort, which is just a group of people that we age through death, population, which we do at the fully national representative level where we try to capture what's going on in any given calendar year. So based on the simulation that we've built, we can do lots of different types of experiments. So I put this into four groups, I guess. So the first is altering the initial characteristics of the population. And so you might do this, you might think of this in a cohort setup where you have a group of 25 and 26-year-olds and you're going to change something about them. So for example, one thought experiment we've done is what if instead of having the BMI distribution that we have today, what if instead we had the BMI distribution that we observed in the NHANES in 1980? And so we would literally adjust the BMI distribution of the initial cohort and then simulate out and say that this is what we think the differences might be with that different BMI distribution. Another big area that we work on is the policy module. So this is changing the structure of how the various policies are implemented. So this is changing the retirement age for Social Security, or it's changing the eligibility age for Medicare, or federal benefit, other federal benefit enrollment rules. The third big group is intervening on the transitions. So I mentioned, for example, the diabetes model that I wrote up before, where it's a function of characteristics. I should say this a little bit in more detail. So the idea with the transition model is for each individual at any given point in time, we can predict a probability of them developing diabetes. And then within the simulation, based on that probability, we'll do a draw from a uniform distribution and assign whether or not they actually developed the disease. So an intervention on that would then act on the probability. And so let's say for an individual, we've predicted that it's 5% probability they're going to develop diabetes. We might think that there is a new treatment that's going to come online, or a new intervention, maybe a lifestyle intervention that would change the transition probability of developing diabetes. And so what we would do is we would intervene on that 0.05 probability for that individual, maybe reduce it by whatever reduction we see in the literature, or what we think might be reasonable. And then we'll simulate out the effect of that at the cohort or the population level. And then the final type of intervention that we'll do is altering the characteristics of those replenishing cohorts. And so the idea there is that, what if we could stop the trend that we're observing in the BMI trajectory of the population? That will happen through the replenishing cohorts coming in with a different BMI distribution, and so we'll get to see the potential impact of that. Okay, so those are the four big buckets. So I really think the way to think about it is the types of questions that are asked in the survey. You can think of implementing them within the simulation, and then you can think of either just reporting on those outcomes based on the things that are within the simulation, intervening on things that might affect those outcomes in these four different ways, or possibly intervening on the new outcome that you've developed. Okay, so we have pretty detailed technical appendices that are at these links. You'll have access to these slides so you can access them. But basically within those, they walk through all the structure of what's going on within the simulation in nitty-gritty detail. They talk about some of our validation exercises that show baseline forecasts, talk about the data sources, et cetera. So anything that I've missed in this presentation is probably covered in those documents. Okay, so I mentioned the things that go into the diabetes model as an example, but and I mentioned many of the outcomes, but this is kind of the schematic of what's going on within the transition. So the things that might be on the right-hand side of your transition models, on the left-hand side of this slide, are age, sex, race, education, these lagged risk factors, lagged disease status, lagged functional status, and then the fixed factors from the childhood. And then the things that they're going to be predicting will be all of these economic and health outcomes that I mentioned. So it's a full set of transition models that will be simulating for each person at any given point in time. I mentioned the replenishing cohorts and the trends in them. So for FAM, this is the set of things that we're going to be trending. So the demographic characteristics aren't mentioned on this slide, so those are definitely done as well. And then we're doing BMI, smoking, hypertension, education, partnership, children, and work status. For the future elderly, it'll be a different set of trends that we're imposing. So since those people are older, they've had the chance to develop diabetes and heart disease by the age that they're going to be replenishing our population. And so we'll trend those things as well. It's all in the technical appendix if you're interested. The next set of slides is just to give you a sense of what kind of the baseline projection that we have, or baseline trends that we're going to impose on those replenishing cohorts are. So you see, like for BMI, what's going on here is the average BMI is definitely going to be increasing, but it's actually, there's several papers on this that show that it's really the distribution of BMI, the right tail is pushing out. And so that obese 2 category that you see sort of trending upward over time, that's that right tail pushing out. So at any given point in time for our replenishing cohorts, we're going to have roughly the same number of people who are in the overweight, BMI 25 to 30, or that obese BMI of 30 to 35 category. That 35 plus category is going to keep pushing out. And then what's not shown here is the people who are not overweight, that'll be decreasing as to compensate for this. And then similarly, we'll have a trend for decreasing smoking. So one of the reasons we initially developed these models is because it wasn't clear which was going to win out between smoking and obesity. You know, if you have an improvement in one risk factor and a negative trend in the other, then we need to try to disentangle what's going on there. So at least in our replenishing cohorts, it's not clear yet what's going to win out. I'm going to skip through a handful of these. So, but these are the trends you would see in our replenishing cohorts and the default version. Okay, so then one of the big questions that people always ask me is, well, how valid is your model? What are you doing to validate the work that you're doing? And this is also in the technical appendix, but I'll just talk through it very briefly here. So one exercise that we do is a cross-validation. And so for that, we'll estimate our transition models on a random half of the sample, and then we're going to simulate starting as early as we can, which in the case of the FAM is 1999, because that's when they started asking the health questions in the PSID. We're going to simulate that half of the population all the way through present, and we're going to compare how we did. And for the health outcomes that we care about, the mortality outcomes, the demographic characteristics, we do well. Then not on this slide is an external validation where I'll also compare our results from 1999 through 2015 with other external sources. So for there, I'll compare to the MEPS or the NHIS or the NHANES or the BRFIS or some of these other nationally representative health surveys. And on those as well, if we don't match the levels exactly, we at least match the trends. And so I think we're doing a pretty good job there. And then the final set of things, which isn't really validation, I call this external corroboration. What we do is we'll compare our forecasts, so this is now into the future, with external forecasts that we think are probably doing a decent job. So, for example, I'll compare a population forecast to the census and see that we do reasonably well aligned with them. Or if I'm doing a diabetes study, I'll look at a CDC model that forecasts diabetes prevalence and compare how we did there, and we do well. And then we do ad hoc comparisons of interventions to various causal estimates that you see in the literature. And I probably should have said this earlier. The structure of our model is really, it's not causal. I wish it were. But it's really a kind of a giant set of correlations is a way to think about it. But we've been pleasantly surprised when we've tried to sort of benchmark our results compared to carefully done causal estimates of outcomes that we tend to be at least in the ballpark of those. So, you know, if there's a paper on education's impact on life expectancy, and we look at that and we try to mimic that outcome, we'll have a similar effect size. In addition to validation, the other thing that people always ask me about is what is our approach to uncertainty? And the basic idea here is that we bootstrap everything. So we're going to resample our population, re-estimate all of our transition models, and then resimulate with these estimates. And then when we do that enough times, we feel like we've captured the uncertainty that's inherent in all of our data and estimation processes. In terms of actually working with the simulation, this is probably way in the details, but all of the data work is in SAS and Stata. The estimation steps are all done in Stata. The simulation itself is written in C++. We have collaborators, most of them work in a Linux environment, but we also have people who use Mac OS natively, and then people who work on Windows machines where they use a Linux emulator. It's really best in a Linux environment, but it is flexible. The code is all publicly available, so that's part of our NIA grant. You probably gleaned from this, it is a lot of code. It is fairly complicated to work with, so if you are interested in working with it, I strongly encourage you to contact me, and I'll help you get started, or we can figure out a collaboration. And so that's sort of the technical setup. So I hope you have a good flavor of what's going on within the model. And so for the next few minutes, I'll just show you a handful of applications that we've done, and then I'll take questions in about 5 minutes. So a year or two ago, we did a project with the Brookings Institute where they had a conference that was focused on forecasting the Medicare population in 2030. And so what we did is we took an FEM population, so then this is an HRS-based piece of work, and we forecasted through 2030, and we said this is our best guess of what we think is going to happen. And so I'll walk you through just a handful of the results. So in 2010, we had our distribution of race ethnicity as we saw in the HRS, and then in 2030, this is what our forecast would show. I think any demographer could do this probably as well or better than we could, but our model does produce these results. We also capture the change in education for the cohorts that we're going to expect to see. And so this is potentially good news for Medicare because people who are more educated tend to follow doctors' instructions better when they are taking their medication, for example. And so we're capturing this shift in the demographics of the population that probably will inform outcomes. We can also produce the kind of pyramid charts of the population sizes. So this is capturing multiple things. So on the left, you're seeing that we had about 40 million people over 65 in 2010. In 2030, it's going to be about 67 million. That's known. It's not surprising. But what is a bit surprising is the push out to the older ages. So we're going to have more and more people in their 90s and over 100 in the population. And so that's going to come with some additional challenges for Medicare. And then I mentioned this before when I was describing the trends in obesity and smoking. This is also true for the older population. So we're having a similar push out in the BMI distribution for the elderly, but we have a simultaneous decrease in the smoking trend. And so, like I said before, it isn't necessarily clear which is going to win out in terms of health outcomes because obesity and smoking are both risk factors for heart disease, for example. And so which is going to dominate? And so we did the simulation, and this is what we expect might happen. So we expect more chronic disease in the future. So for each of the diseases that we're looking at, we expect them to increase. And then moreover, we expect to have more chronicity of disease. So this is looking at the number of people who have 3 or more of these chronic health conditions that we're simulating. And so that has implications for the quality of care that people need to receive and continuity of care. And so the net effect, the sort of punchline of the paper is that people are going to live longer. So we expect to see this increase in life expectancy. So for men from 17.3 up to 18.3. But that gain in life expectancy is actually in disabled life years. And in fact, the total number of disabled life years is going to increase, I think, for both men and for women, based on our forecasts. I think just based on time, I'm going to skip. I'm going to do one more. This is a quick one. So this was a FAM-based simulation that we did. And the research question was, what is the impact of expanding childhood health insurance? And so what the research did initially is they looked in the literature to try to find causal estimates of the impact of expanding childhood health insurance. And the main result in the paper is that kids who lived in states that expanded health insurance, they had this causal estimate of an increase in education by age 25. And so within the model then, the authors took that effect and they said, well, what would happen if we had a cohort of people who then might now be eligible for a health insurance expansion, which would then have this impact on their education? What might the life course implications be? And so you see that there are, since education is associated with all of these chronic disease outcomes, they have these effects. So less heart disease, less diabetes, less, stroke into the future. You'll see an increase in cancer. I'm going to explain that by saying that I think it's it's a survival issue that more people are living to older ages to develop cancer. But then the policy perspective that they took on this was that in the status quo, if you look at the lifetime disability claiming, you would have the dashed blue line, but under this intervention where these people had the health insurance effect of then acquiring more education, it decreases their lifetime likelihood of claiming disability. And so maybe you could justify the investment of the health insurance expansion at present based on these future decreases in disability benefit outlays. This is my last slide, and then I'll take some questions. So we also, one of the papers that I probably should add some slides on, because we're really proud of this work, is with Professor Heckman's team at the University of Chicago, that's looking at the abecedarian early childhood education program from the 1970s. And so that was a randomized control trial in the 1970s. They followed those kids through today. And so what we did is we then took that cohort of people and we simulated them through using FAM, and we predicted what their the rest of their life course might look like from a health perspective. And so we were able to say that the benefits of that early childhood program were justified by the health outcomes alone. And then there's also a lot of additional outcomes that Professor Heckman's team looked at, such as lifetime earnings, educational attainment, prison, and a handful of others that made it a very cost-effective program. So with that, I think I should give you back the screen, and I'll take any questions that have come up.
Great, thank you, Bryan. We do have a few questions that have come up. We're pulling them up in just a minute, but I think the first question that came to me was, you talked about most of this being publicly accessible, and I'm wondering, is there a specific web page or resource where people can go to kind of learn more about how to be able to access this?
Yes, there is. So on our main Roybal page here at USC, I think it has a link to it. But if you're interested, you should. I strongly encourage you to contact me, and I will forward you all the documentation and let you know what's involved in getting up and running.
Okay, great. Yeah, I certainly concur with that advice because it seems fairly complicated. So to just go through the questions, and they're posted on the screen as well. You talked about different ways of validating the data, but I didn't necessarily hear you say that something had happened like this, which was how well do simulation experiences done in the past, for example, 2015, correlate with true observed data for the present? Have you done that and what have you seen so far in terms of the model's ability to predict what we already know?
Yeah, so that's a lot of what we're doing in our validation exercises, and so a lot of it is focused on, like I said, starting in '99 and simulating through the present. I guess one of my, I really think of what we're doing as, how should I say this? Our forecast for 2030, for example, that I was showing, I worry that when it gets to be the year 2030, people are going to come back and say, look, you guys weren't right, you missed this. But I guess from my perspective, I think that it's going to be okay if we aren't right, because I'm hoping that in the intervening years, we're going to do some interventions that improve what Medicare looks like in 2030. But in terms of the like more recent, like how well did we do in terms of the real data, that's all in the technical appendix, and I think it shows off pretty well that we're doing reasonably well. What we do miss are the big shocks. So, if you did a simulation in 2007 and you were trying to predict what happened in 2009 or 11, we're going to miss the crisis. And so, there's always that caveat that, it's really based on the things that you're observing in the PSID, assuming that those effects are stationary, and then what's driving all of the changes are really the trends that you're imposing on those replenishing cohorts coming in. So.
Got it. You did provide one link to a journal article. Is that an ideal reference journal where people can get more details of the model itself?
Yeah, so what typically happens with our journal publications, and I'm happy to send a list of publications around as well, is they'll have a technical appendix that goes along with them, and those technical appendices are based on the big technical appendix that I can distribute to people. So
Okay, but is there, or maybe, I mean, a list would be great, but I think people might be really happy if there was maybe one or two key ones that would be a great starting place for individuals.
Yeah, sure. So the Heckman paper is probably, it's a bit challenging. It's got a lot of other stuff in there. The Medicare 2030 is probably a good place to start.
Okay.
That's the one with Brookings.
So the Brookings paper is an ideal place to start.
Yeah.
Okay, great. So we're pulling up the next set of questions, which is, can the model also go from protective factors to lack of disease, and then look from there to, you know, potential positive savings or, you know, economic outcomes that are not negative, for example, as opposed to
definitely. And I'm sorry if I gave the impression that we only focus on bad things. No, so a lot of the work that we do is trying to understand the potential value of either, like work I'm doing right now is looking at what if we were able to have the diabetes prevention program at the national level, what would the benefits of that be? And so that would function through decreasing risk factors, limiting the transition of disease, and then people would stay in the labor force longer, or they would have lower medical expenses. Although, as I say that, I'll give the caution that a lot of these things, you won't save money on medical expenses because people do tend to live longer and cost more. And so that's where we turn to doing a quality adjusted life here. And we value the benefit of, you know, living longer or living the same length even, but in better health. So definitely we can do things that have a rosier outlook.
Great. And then can simulations be set up and done as comparison? For example, can you do two simulations within two different racial and ethnic populations in order to compare them?
Absolutely. And so a lot of the work we do, and I should have shown this as well, so work with Maria Prados, for example, looked at an intervention and then looked at the African-American population compared to the Hispanic population and what the benefits might be based on an education intervention using the kind of correlations that we saw within the PSID. So I do caution people, we do look at subpopulations. You're always at the mercy of the host data. So, you know, if you wanted to look at, for example, you know, a very small subpopulation, like a particular age or a particular race, sex, education level, sometimes you get into really small sample sizes, and you need to be really careful about how to interpret your results and think about them.
Okay. Are there other questions that people want to ask that maybe they didn't include in the chat? So I'm going to let people think a little bit and just do a plug for our evaluation. I just posted accidentally twice 2 links to a very quick, it's just a 5-question survey that we really would appreciate your responses to in terms of the seminar. And of course, you know, we are an NIH-funded center, so the evaluation piece is always something that's useful. And we're just showing it quickly there to indicate that I'm true to my promise that it's a very easy thing for you to get done. And so then to go back to questions, I guess I had another question which I'm trying to formulate. So obviously this is a very complex model, and then it seems like you're able to provide at least some support for running it. But I'm wondering, maybe you could give us an idea of if one has a relatively simple question, are we talking like months to get this done? Or, you know, are there questions that people can answer within reasonably short amounts of time with this model? Or maybe you give us a sense of what, you know, what kind of how quickly one can get different types of output out of the model.
So it's a good question. It really depends on the type of work that people want to do. So if it's a set of you know, looking at things that are already built into the model, using the kinds of interventions that we're used to doing, looking at particular populations that are already developed, those are very easy to do. You know, weeks, at most. So I shouldn't say at most, but on the order of weeks. If you're talking about developing, you know, like for example, the PSID has some module that we've never even touched within the simulation. There's going to be a lot of data development and simulation development and validation. Then you start talking about months or, you know, over a year. So.
Okay. That's helpful. And are there pieces of it that one can run without, you know, being a high level, I mean, with support, obviously, but can run without necessarily being a high level biostatistician?
So yes, I think that, yeah. So for example, you don't need to be a C++ user at all to use the simulation. We train people all the time to work with it who have no experience in that. They're running simulations. They're getting out results that they're interested in, that are good results, using things that are sort of built into the simulation. They sort of need to be trained up to work with, but you know, not really heavy lifting on the programming side. We do tend to, like I mentioned, we have a lot of programmers here who work on this. We tend to partner up with people when they want to do a research project to make sure that they understand, you know, what they're getting into. And we're happy for people to do their own programming, but at the very least, we want to have some feedback so they understand the nuances of what's going on and how to work with it.
Great. So there's a number of people still on the call. Are there additional questions that people have for Bryan?
Well, don't hesitate to email me. I'll put my email in the chat box right now, just in case you want to note it down right away. It's also on the slides. Here we go. I just saw a question pop up. How easy is it to use another data source in the simulation? So that's a great question. If it has the same structure as the health and retirement study or the panel survey of income dynamics, it's fairly easy. It's very easy if one that has been harmonized already. So here at USC, there's a group called the Gateway to Global Aging, and they've actually harmonized a lot of the international surveys that are like the HRS so that it shares variable names and measures. NHAT, I don't think is like that. I'm not that familiar with it, so I would guess that would be a much bigger undertaking. The thing that you'd want to look for always is a longitudinal panel survey, because that's the key thing. You need to see the same people again over time so you can estimate these transition models.
Okay. So just a couple of general questions that I've been asked related to the webinar. If there's no more specific questions for Bryan, the webinar has been recorded and we'll post it to our website. You see the URL there, but it's rickmar.ucla.edu. I think Bryan's also willing to share the slides directly. It might be best to share those if you actually give us your email in the chat, so that we can make sure we get the slides to you directly. And I want to just confirm that with Bryan. And we will be planning another webinar likely for January, but you'll have to, you know, follow us or pay attention to the emails to get the specific date. I apologize, I don't have that yet. And I think that was all the kind of general questions that I had, unless somebody has others. All right, well, thank you once again for joining us. Thank you, Bryan, for your really interesting presentation. And I actually have already research questions I'll probably be following up with you about. But thanks to everyone who participated today.